Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello everybody. First of all, I would like to thank very much the organizers for the invitation, and in the next minutes we're going to speak about solid masses of the school base. Pediatric school-based lesions are rather uncommon as individual entities. They can arise from many different tissue types, they can have an heterogeneous appearance, and they can appear in different locations. So there might be some overlapping of this lecture with others, but I think it reinforces the message that we are all focusing on the most common or most characteristic entities. We will discuss some benign, malignant entities, some mimicries as well, and the imaging techniques that we're going to use will be mostly MRI as the best technique for complete lesion evaluation. But in this lecture, regarding school-based lesions, also CT is very important to assess calcification and accurate bone analysis. And regarding problem solving, staging, and treatment response, remember that FDCG can also help a lot. The MRI protocol that we will use will depend on the exact region and boundaries. If we're talking about properly the school base, if it extends to the neck, if we're going to check about the orbits, and we will most of the time use axial coronal T1 or T2 with and without back suppression. Of course, diffusion helps a lot, and we will generally, I think, use contrast enhancement in most lesions. Of course, we have optional techniques that we can add to this basic study. Our first case is a quite classic but uncommon lesion with involvement of the nasal fossa, maxillary sinus, orbit, and anterior granule fossa. There is bone destruction with spicules and calcifications, and also strong enhancement, both by CT and by MRI. By CT, you could easier see the soft tissue component in which you can find cysts here, and although this imaging is not specific, it is quite characteristic of anesthesioneuroblastoma. Anesthesioneuroblastoma arise from the olfactory neuroepithelium with neuroblastic differentiation. They usually appear in the second and the sixth decades of life, but they can also appear in children. And despite the inadequacies and attempts to use different staging systems, the Kaddish system is the most commonly used. And we're talking about stage 1A when it's confined to the nasal cavity. If it extends toward the paranasal sinuses, it will be stage B, and stage 3 when the invasion is beyond towards the orbits or the intracranial cavity. We will use CT for bone assessment. We will focus on remodeling, destruction, bone, spicules, scattered speckle calcifications, and we use MRI for soft tissue extension of the cyst I already shown you. And remember that lymph node extension is quite common in this disease. But there are also other tumors that can affect the nasal cavity and the anterior cranial fossa as well. One of them can be Ewing sarcoma or aggressive soft tissue sarcomas, but this is not the case. This is a right-sided mass arising from the nasal cavity, eroding the skull base, so the cleariform plate, and extending into the anterior glandular fossa. You will see both components, the vasogenic edema here. We might think there should be some restricted diffusion, but imaging was with a lot of artifacts due to the orthodontia that this patient had. So I can assure you that, but you can see that this is a very aggressive lesion that arises here, and it has both components. And this is in fact a sinonasal carcinoma. It is quite uncommon regarding that it has less than 5% of all sinonasal tumors. It appears in the early adolescents, and in children it is related to Epstein-Barr virus. There can be lymph node involvement, and there is a common cranial nerve involvement regarding this invasion. And the differential should be other soft tissue sarcomas like rhabdomyosarcoma and lymphoma as well. Remember that esthesioneuroblastoma and Ewing sarcoma can also have the same appearance and behave in the same way. If we move to the medial cranial fossa, this is an example of an aggressive solid lesion in a patient with diplopia. and 6 nerve cranial nerve palsy due to the invasion of the cavernous sinus and the sphenoid fissure. I don't have the CT, but you can see that the bone is completely destroyed here and this invasion towards the middle cranial fossa. They can see that there is restricted diffusion and avid FDG uptake. So this is an aggressive lesion, and this is a rhabdomyosarcoma. Here it arises from the nasopharynx, but very up above, and it expands into the skull base. And this is called a parameningeal rhabdomyosarcoma. We'll focus on that later. But remember that with MRI, we can not only assess the imaging at the beginning, but also after follow-up. And after chemotherapy, you can follow up not just the shrinkage of the disease, but also the increase in the ADC values, which reflect a good response to the chemotherapy. This is another case, a little bit below of the same pathology, with a cavum, left parapharyngeal, and amygdala mass that obliterates the stacking tube. That's why we have fluid trapped in the mastoid cells with low ADC and avid FDG uptake with lymph node spread. This is the same lesion. And I'm not going to comment about orbital rhabdomyosarcoma, which is quite common area in which this disease can happen. They have a worse prognosis, but I'd like to comment on parameningeal because they have an unfavorable prognosis regarding invasion of the CNS through the skull foramina. And this is important to remember. Of course, in our setting, most of the subtype we will see will be embryonal rhabdomyosarcoma, and it can be associated with predisposing syndromes like Di-Fraumeni, Dicer, and NF1, among others. And remember that FDG PET can help identifying recurrence in these patients. Our next case is an uncommon disease, but also classical one. And it can sometimes involve the middle cranial fossa because it's a very invasive and aggressive local disease. It was a 4-year-old boy with cranial nerve palsies in which you can see the destruction of the clivus here. You can see remnants and maybe some inner calcifications as well in a mass that expands towards the brainstem and it places it backwards and encases some of the vessels as well as some cranial nerves and expands not only in the posterior cranial fossa but also in the middle one. And at the same time you can see that both internal carotid arteries are encased. As I'm sure you know, this is a chordoma, which is a very local invasive disease, a slow-growing malignant tumor arising from remnants of the primitive nut cord. It has a high rate of recurrence because it is very difficult to remove surgically all of it. And although it is rare, it can appear in children. And in children less than 5 years old, it has a poor prognosis, mainly to this extended extension at the beginning or at the diagnosis of the disease. With CT, we could assess bone destruction, and it has a typical lobulated appearance, and typically it is hyperintense in T2. I'd like to comment on this benign developmental variant, which is arrested normatization of the sphenoid sinus, which is something that you will see commonly in your studies, and also your adult counterparts will come to you and ask you, hey, what is this? And this is nothing to worry about. You just have to check that it is an unexpansive lesion with osteosclerotic borders. It can have internal fat and curvilinear calcifications. You can see how it behaves in T1 here, which has fat and also hyperintense in T2. Enhancement can be a variable, but CT will help you very much in defining that this is not an expansive lesion and that it respects the boundaries. It respects the cortical of the bone and also the inner nerve that can go inside. I'm just pointing here the left cranial median nerve. You can see the channel here, and you can see that in the other side it is respected as well. So you can be pretty confident that this is nothing to worry about. And it can appear in the basisphenoid bone, in the pterygoid process, and in the clivus as well. This entity is quite straightforward. It's a craniofacial fibral dysplasia, which is a developmental benign medullary fibro-osseous process in which what happens is there is a failure to form mature lamellar bone. So that's why it has its appearance. We will look for expanded bones with intercortex and this young glance appearance in In later stages of the disease, it also becomes mixed with lucencies and sclerosis. And of course, the clinics starts with compression of the orbital content of the cranial nerve as well as facial deformity sometimes. And it's something that we commonly diagnose in young children and teenagers. By MRI, you can have an heterogeneous appearance and it can be related to some syndromes like McCune-Albright syndrome. Sometimes they can degenerate, but it is not very common. And another hint that can happen in these children, you can see the follow-up of this child from the beginning of the disease as 5 years old, at 18 years old, when we can find this lucency here in the upper part of the lesion. That we said it could arise from the sphenoid bone, but we have to check what is happening here. An MRI will help you better. And as you can see, what happens in this kind of lesions is that sometimes they can develop an aneurysmal bone cyst, which is what happened in this child, in which you can see these 3 cysts with fluid level, and you can see that it's blood here. So these are aneurysmal bone cysts that need to be treated in this case because the symptoms really became worse due to the growing of the cystic part. We've already seen some of them, but of course you can also find lesions in the upper part of the neck related to the skull base, and you should pay a lot of attention to skull base foramina. This is very important. If I tell you the context of this patient, you will surely guess it very, very quickly. We have this lesion here in the prepharyngeal space, lobulated, T1 hyperintense, but if you look closely at the rest of the images, you will see we have thickening and high T2 signal of the hippocampus here, as well as some lesions here in the caudate nucleus in a patient that of course has an FF1. This actually is a plexiform neurofibroma. But please check always the skull foramina, because this neurofibroma arises from the foramen ovale, from the third branch of the trigeminal nerve. These kind of lesions are almost pathognomonic of NF1, and it happens in roughly 30% of patients with NF1, and they can happen anywhere in the body. It looks like a bag of worms. It has this T2 hyperintensity, and they can have malignant transformation. So this patient might need surveillance. If you're interested on that, please check the European Reference Network guidelines. That they are specially developed for student and other genetic predisposing syndromes, and treatment usually is not for surgery regarding the extension of the lesion, and lately MEK inhibitors can really help in some of these patients. Just to check it better, you can see the expansion of the right foramen ovale here in the CT reconstruction comparison to the other one, as well as in the MRI, in which there is thickening of the third branchial of the trigeminal nerve, and there it goes down this plexiform neurofibroma. I'd like to show you another entity that can also extend towards the skull base, although it is not typical of this area. You can see here this 11-month-old child with a history of a 6-month slowly growing, we call it lymph nodes, but of course this is not a lymph node. And you can see this lobulated hyperintense T2 mass in the posterior neck right in front of the lung muscles, with areas of low ADC and heterogeneous enhancement. This in fact is a neuroblastoma, which you know it's the most common extracranial solid tumor. And it accounts, it's mostly in children very young. The average will be between 1 and 2 years old, and most of them below 5 years. And they origin from the primitive ganglion cells from the peripheral sympathetic nervous system. So what happened here is that, of course, we have peripheral sympathetic nervous system here in the neck and up to the skull base. At this level, the peripheral sympathetic nervous system is closely associated with the deep cervical fascia, and it forms, one of its leaves forms the part of the carotid sheath, the posterior part, so this tumor arises initially between the muscle and the carotid space. And apart from its origin and MRI appearance, you should also check for CT that can be very helpful, because neuroblastomas commonly have inner calcifications. But regarding skull base lesions, neuroblastoma is very important regarding its metastatic potential, because almost 50% of all these tumors can have metastases, and most of them will be to the bone, especially to the mandible and to the skull base. It can also expand in certain cases to the CNS, in which in these cases what they do is they have this kind of lesions which are very bizarre, very aggressive, and very bleeding. But regarding skull-based lesions, what you will find is this kind of lesions that this patient had in the right mandible. You can see this aggressive lesion with periosteal interrupted reaction. Patient had also another one close to the sphenoid in the anterior part of the orbit, which I'm not showing you. And these lesions are very aggressive. They have low ADC and this heterogeneous appearance in this child whose primary neuroblastoma was in the left adrenal gland. This is another example, another disease with multiple skull lesions. I'm sure it has been covered before, Langerhans histiocytosis. They are painful. It can look lytic lesions regarding CT, X-ray as well, but they are solid, they are very painful, and they can be very infiltrative. And of course, they can have CNS involvement as well. The disease, and the most common find will be the lack of this hyper T1 spot of the neurohypophysis in T1. So look for that because it really changes the staging of the patient, and treatment should be reinforced when there is CNS involvement. Just to show you one lesion in which you can see that the solid component, in which there is, of course, destruction of the bone, and this inner component also into the orbit, and this infiltration or at least reaction of the dura mater here. Next case is an important pathology to know because it can be life-threatening. This is a case of a child which was 5 years old with rhinolalia progressive snoring that was very rapidly evolving in less than 36 hours. So you can see that even within contrast, we cannot find the boundaries by CT of the lesion. So it was an emergency, that's what we did, a CT, but it clearly cases the vessels. We cannot see the jugular vein, and in fact it invades the left jugular foramina in the skull base, and it really narrows here the airway. So be careful with this lesion. With MRI, you can see that there is low ADC, and with contrast, with MRI, we can see the central hypoperfused areas regarding rapid tumor growth. So this is something to worry about, and this is one of the fastest growing tumors that we have. It can double its size in just 24 to 48 hours. This is a Burkitt lymphoma. It's highly aggressive. It can happen in any age group, mainly between 5 and 10 years old, and it has good chemotherapy response. We can have a sporadic and endemic forms. Endemic forms is more related to Africa and to Epstein-Barr virus infection, and it's more aggressive towards bone, towards skull base, with more invasion and more necrosis as well. It can also spread to the CNS, and even it can also originate. It's rare, but it can happen inside the CNS as a primary lesion, as in this child whose primary lesion was in the spine. And the last pathology we are going to review is the following. This is a solid heterogeneous mass in an 11-year-old child with nasal stapiness and epistaxis, which is a solid heterogeneous mass that extends through the pterygopalatine fossa, expanding and eroding the pterygoid process and the posterior wall of the maxillary sinus. It also expands towards the choana and into the nasopharynx, and there is avid contrast enhancement both by CT and by MRI, in which it has this salt and pepper appearance, and it is also very well and very highly vascularized by the internal maxillary artery. I'm sure you all know what this is, but please remember that this can sometimes be a life-threatening lesion due to epistaxis. This is a juvenile angiofibroma, which is histologically benign, but a local aggressive vascular neoplasm. It's typical from teenagers, but as I showed you before, it can happen in lower ages. I think the youngest one we've seen was 9 years old. And due to this epistaxis, it is very recommended to perform embolization prior to any surgery or biopsy. Its origin, most authors agree that it's related to the sphenopalatine foramen, and from here it can expand to the pterygopalatine fossa toward the choanus, or maybe having this thumb-shaped appearance in both sides. And this mutation is having by most of the patients. So with this, we are finishing. As a summary, you've seen that we've covered different entities with many possible tissue origins. Some of them can be benign, some of them can be malignant, some of them can act as mimickers, and we just focus on the most common or most characteristic. And apart from this take-home table, I'd like to share with you some reference that you can download with this QR code. And with this is my last slide, in which I'd like to thank again very much the organizers for the invitation, many colleagues from my department, imaging department, neurosurgery, ENT, oncology, and all of you for your attention. Thank you very much.